Yeah, good evening once again. So we are live and the record button is on. Welcome again to Afro DX. And today we are going to have a case. We missed David for a while, and today is going to show to come back fresh and enthusiastic. Uh, yeah, so I think everything is all set. David, are you ready?
Yes, I'm ready, but for the same reasons that you mentioned, I think it's been a while I haven't discussed the case, and it's also been some weeks we haven't done Afro DX clinical unknown sessions. So I feel a little unfit to do a case today, but so this will be a jogging session. I'm ready for it.
Okay, I can tell you are never unfit. So, what we have for today, let me admit some people. Okay. We have a 41-year-old female who was admitted in the hospital I was working, and I was called to see her. She had generalized weakness as the main complaint.
Okay, thank you, Joseph. So generalized weakness. I recall, I think a few months back we had a similar complaint of generalized weakness, and I think at this point I should just reiterate that generalized weakness I think is a very broad complaint, and therefore at this point in time I think I shouldn't even attempt to start and tease out what exactly is going on, because I think there is more than 1,000 things that can present as a generalized weakness. I mean, if I just try and throw in some possibilities, I mean, it can be anything from something hematological, like a patient with anemia, which again has so many causes, but it can be something endocrine, like someone with hypothyroidism, for example. So I think there are so many things. It can be something neurological. So I think the history will at least help us to narrow down and see which path exactly I can focus on. So more history.
Yeah, that's a very good start. So we go back 8 years where this disease starts, and so she says that 8 years ago she noticed her legs and arms were getting weaker compared to her baseline at that time, and she reports to have sustained multiple falls back then. And in one of her falls, she sustained a fracture of a femur. So her daughter was in the room, and she gave extra together with her mother. So she and her daughter described the fall as too trivial to result in a fracture in an otherwise healthy person. And they went to OT surgeons. The OT surgeons did X-rays, and they told her her bones were osteoporotic, looked like someone in elderly female, but she was young. But the weakness progressed over time to the point that she couldn't walk unassisted or carry activities with her arms that she previously performed without a problem. And she also noticed gradual abdominal swelling over time. She says that she had multiple ultrasound of the abdomen done to her, and they were reported normal. She also reports a generalized rash that is non-pruritic, non-blistering, and non-painful. She has never seen her menses for 10 years now, and she reports a significant decrease in libido since then. And so over that time period, yeah, she also reports difficulty with sleeping. Her daughter reports that sometimes she would forget important events. She would also have episode of confusion and failure to plan things that she didn't have previously. She also reports multiple previous admission in hospitals in and out for the current infections of the GI and chest, but she denies the history of fever, abdominal pain, diarrhea, numbness or paresthesia, cough, shortness of breath, chest pain, muscle pain, difficult painful urination, and abnormal PV discharge. That's HPI.
Okay, thank you very much, Joseph. I think this is going to be a lot of fun, but again, this case is very packed, and I think there is a lot to be unpacked. So I'll just try my level best, but yeah, I think it's a very interesting case and a very difficult one at the same time. The weakness now, so you the way you framed it is the patient presents with weakness, which is manifested by a number of falls, one of them leading to a femur fracture. Now, what I'm thinking of is, again, I think we've discussed a number of cases here, so I recall a number. At one point, I also talked about this is sometimes you hear about weakness. So, for example, when we hear weakness that leads to falls, the question that comes to my mind is, are we dealing with a true neurological weakness, or are we dealing with something else that can mimic a neurological weakness? So that other thing can be something like asthenia. So someone is having prostration, for example, from something like anemia that I mentioned earlier, that someone doesn't have that someone doesn't have neurological weakness, but they have generalized fatigue. So that could be one. But then you also have other things like someone can have apraxia. So the muscles have normal power, but then it's failure in coordinating those fine movements that can present or can be confused with weakness. So this patient has had multiple falls, but then at least up to this point in time, I can say I haven't seen any specific pattern that enables me to think about it as a true neurological weakness or something different. So that's it about the weakness. But then uh, something else came here, uh, that the patient has abdominal swelling. Now, with the abdominal swelling that you are talking about, I do not remember seeing whether it's progressive or not. But then, if we are talking of abdominal swelling again, I think at this point I should just share my a few mnemonics and heuristics that I use to wake up a patient with abdominal swelling. I would think maybe this is fluid. I think we know that. So that could be fluid, and that we are commonly talking about ascites. I think just a few weeks back, I presented a case of ascites to Joseph. I do not remember if we had a recording of that, but if we have it, I think for those who missed it, it will be very helpful to go and revise it. So fluid, it can be a fetus. So this is a 41 years old female. Yes, still premenopausal at least by age, but then we hear the patient hasn't had menses for 10 years. And then it could be flatus, it could be fat. So, but I think the commonest of them all, or at least what we would be biased towards, is fluid. But then ultrasound would have been able to pick fluid. So uh, maybe the fluid is not intraperitoneal, maybe it's something else. The ultrasounds are reportedly normal. So what puzzles me about this patient is we see we see presentation in multiple organ systems. I would think about it that way. There is weakness, which we haven't concluded if it's true neurological weakness or not. And then we have abdominal swelling. Uh, and then there is also a generalized rash that is non-pruritic, non-blistering, and non-painful. So we see some signature in the skin, probably some signature in the GI. With the weakness, we cannot exactly localize it. But there's something else that I do not want to miss. a fall on level ground, and then someone sustains a femur fracture. And of course, the OT surgeon mentioned about osteoporosis. So we should not miss that. So there's probably, whatever this patient has, there's some signature in the bone as well. But then when we move away from that, we also see that the patient is presenting with difficulty in sleeping. And there are some cognitive symptoms also. For example, we see a bit of forgetting important events, episodes of confusion, and failure to plan things. So whatever is going on in this patient, it could be different things happening in different organ systems. But at least my initial bias would be we are probably dealing with one thing that is presenting, that is leaving its signature in multiple organ systems. So that will be my first way to think about it. I think it's no time yet to give any differentials, but I'm starting to think about a number of things. But then you say that's the end of HPA. I would like to hear about the review of systems, other components of history, in order to see if I can pick anything from there.
Thank you very much. And so, past medical history, because review of other system, all system are mentioned there. So, past medical history, she was diagnosed with diabetes mellitus in her early 30s, and I didn't well respond to oral hypoglycemic drugs. So, after 2 years, she was transitioned to insulin. She also was diagnosed with hypertension around the same time. She has no any past surgeries. As of meds, she's currently on insulin, losartan H, and amlodipine. Her family and social history: she's a non-smoker, she doesn't drink. She previously worked as an accountant, but currently she's unemployed because of her healthy status. She's single, she has one daughter who is healthy. She has multiple brothers and sisters who are healthy. And her father died of stroke at age 80, while her mother died of breast cancer at age 73. If you can share anything on that.
Okay, let me see the past medical history.
Okay.
Yeah, so diabetes in her early 30s, which did not respond to oral hypoglycemics, and currently on insulin, also a patient with hypertension on losartan H and amlodipine. Okay. Um, yeah, so whatever we are seeing in this patient, is it related to these chronic illnesses, the hypertension and the diabetes? Maybe, maybe not. And uh, in the HPI, there was something else that you mentioned. This patient hasn't seen her menses in 10 years. Am I correct?
Yes.
Okay, so that's another thing. So, like I said earlier, we are probably dealing with one pathology uh, that is manifesting in multiple organ systems. And okay, so at this point in time, if I start making some hypothesis, one that would closely fit is hypothyroidism, but not perfectly fit. Hypothyroidism would present with weakness. Okay, I should say hypo and hyperthyroidism, but then uh, I'm more inclined. Okay, both of them they can present with weakness. I think we all know that hyperthyroidism can present with weakness, some sort of a myopathy, or sometimes what is called hyperthyroid periodic paralysis, but then that is transient, not present all the time. Hypothyroidism generally presents with generalized weakness, but out of the two, hyperthyroidism would present with insomnia, while hypothyroidism commonly presents with hypersomnia. I think the patients are more sleepy. And then hypothyroidism uh, presents with mixed edema. So swelling maybe of the limbs, including ascites. I believe ascites can be a presentation of hypothyroidism. And then missing menses. So uh, the menses can present with hypothyroidism as well as hyperthyroidism, but then we haven't had a mention of other features of hyperthyroidism like an anterior neck swelling. If this patient is having awareness of heartbeat, I do not remember hearing about weight gain or weight loss. So, but at least I think the thyroid is one of those things that we can consider. I mean, that we need to think about in this patient. Thyroid dysfunction, both hypo and hyper. But then these are two opposing things, and they can share some features. They are very different in other features, but thyroid dysfunction is one thing that I need to consider. When it comes to forgetfulness, uh, definitely hypothyroidism can present with that. So someone is like they are having some sort of cognitive impairment, but not exactly. So I'm thinking about the thyroid as one of those. But then, just like I said, it's just some hypothesis that I'm trying to throw in. But then I think there are many more things that I need to think about. So uh, let's see other components of. I think we're done with the history. So physical exam to see if I can get my head around it.
Okay, thank you very much. Here's the exam. So she's alert, she's a febrile, she's not pale, she's not jaundiced, she has no lymphadenopathy, no lower limb edema. She has hair growth at the upper lip and arms. She looks older than current age. Skin exam, so she had multiple stria, she had multiple pupilla, she had hyperpigmentation of the skin. So she's a light-skinned African, but currently she has hyperpigmentation. Her skin is atrophied, and there is a 1 centimeter diameter ulcer on the right deltoid region where she injects insulin that she says had failed to heal for some time, and it has an eschar. I took some pictures. So this is the left arm, and on your left side you can see the pupilla and the hair. So you can see the hair, and also she saw she gave me her previous picture when she was healthy. She's very light skinned. So this what you're seeing here is hyperpigmentation that has occurred over time. And around here you can see the ulcer with an eschar that has failed to heal. So neuro exam, higher centers are normal, cranial nerves are normal. She has wasting of the upper and lower limbs. The power is 4 out of 5 in all 4 limbs. She has a normal deep tendon reflex. She has a normal plantar reflex. She has a normal finger nose test, and she has an intact sensorium. For abdomen, she has a distended, baggy abdomen with multiple striations. It is non-tender. There is no organomegaly. She has a tympanic percussion note. Respiratory system, cardiovascular system were unremarkable. Neck exam was normal.
Okay. Thank you, Joseph. So, just like I said, this is an interesting case. We are probably dealing with uh, one thing presenting in multiple organ systems, uh, but sometimes you think you have the answers, but you don't. But then I see something else. I've added one possibility here. So this is a 41 years old female um, who started presenting with generalized weakness with multiple falls, and then she sustained a fracture. That was 8 years prior to presentation. She also presented with a skin rash that is non-pruritic, non-painful, non-blistering. She presented with abdominal swelling. She also presented with missing menses for 10 years. She's presenting with insomnia, episodes of confusion, memory lapses, and failure to plan things. So those are the multiple organ systems that I'm talking about. So, and another thing is she was diagnosed with diabetes in her late 30s, which failed to respond to oral hypoglycemics, and she was kept on insulin. Also diagnosed with hypertension on losartan H and amlodipine. So just by pattern recognition, something else that comes to my mind is hypercortisolism. Hypercortisolism. So hypercortisolism in general. So excessive levels of cortisol. What is the source? Are we talking about the adrenals? So cortisol comes from the adrenal cortex, right? Yes, from the adrenal cortex. So are we talking about primary hypercortisolism that is from the adrenals themselves, or are we talking about uh, Cushing's disease? I believe that's the term, Cushing's disease, if it's from the pituitary producing excessive ACTH and then the ACTH stimulating the adrenals, or are we talking of ectopic secretion of ACTH stimulating the adrenals? But generally, something else that I see that could explain at least most of the things in this patient is hypercortisolism. So, Cushing's can present with patients with Cushing's generally have uh, glucose intolerance, which can, of course, can be full blown, can progress to full blown diabetes. And another possibility that I didn't mention is it could be exogenous steroids, like someone taking prednisolone for a very long time. We do not have that history in this patient. But then you can have patients with hypercortisolism because of exogenous use of steroids, even on the skin, rare cases of that. And so some of these can actually present with adrenal insufficiency on withdrawal of those steroids. So I'm thinking of hypercortisolism as another uh, possibility in this patient. Why? Because so the muscle the weakness that we are seeing could be uh, myopathy from the hypercortisolism. Those patients present with a myopathic picture. And then the menses, of course, patients with hypercortisolism can present with amenorrhea. The skin atrophy that we see, the stria that we see, can be explained by hypercortisolism. And again, the abdominal swelling. So these patients could be having central obesity. We didn't hear about a buffalo hump, about a moon face. We didn't hear about the BMI of the patient, but probably this patient is overweight or obese because of the excessive levels of cortisol. And then cortisol can explain the hypertension, can explain the diabetes, can explain the insomnia, and can also explain the confusion and the other cognitive symptoms that we heard about. So, like I said, sometimes you could think that you have all the answers, but maybe you don't. But one of the things that I think a huge possibility in this patient is hypercortisolism with the skin atrophy, with the purpura and everything. But the hyperpigmentation now, patients with hypercortisolism uh, do not really. I mean, as far as I can recall, I do not have a perfect memory, but hyperpigmentation, I do not remember if it's a presentation of hypercortisolism. So that's the one thing that I cannot really explain at this point. So that's just one, I think, one broad thing that I have is we are probably dealing with hypercortisolism. Now, locating exactly where this hypercortisolism is coming from is what I haven't been able to do yet. I think labs can help us do that. So that is one huge possibility. Are there any other things that can explain this patient's presentation? I think I have a poverty of differentials today, so that's what I can think about mostly. But then hearing the labs and other parts that are remaining, I think I can change my mind at any point. So other components of this presentation. The next aliquot, please.
Yeah, thank you very much. Your fresh mind is on fire, my friend. So we move on, and here are the labs. So her white count was 12.3, slightly elevated, with predominantly leukocytosis. Oh, lymphocytosis, sorry. Other differentials were normal. She had a mild microcytic anemia, platelets were normal, renal functions were normal, liver enzymes were normal, electrolytes were normal. HbA1c was 3.4. I looked in the chart. I also saw some other clinicians who had ordered the tumor markers, AFP, which were normal, but CA125 was slightly elevated at 36.7. Machine's upper limit of mono was 35. HIV was negative. Hepatitis B surface antigen was negative. Hepatitis C antibody was negative. ESR was 20. Urine analysis showed the ketone plus 1 and proteinuria plus 1. They also had ordered free light chains. So the kappa light chains were 5.4 elevated. Lambda light chains were 3.1 elevated. I've calculated for you the kappa lambda ratio, which was 1.7, also elevated. Yeah, the abdominal ultrasound showed a gallbladder feed with a sludge bile and the pancreas with homogeneous echoic echogenicity. The radiographer queried chronic pancreatitis in the report. Also, there was a normal spleen size with heterogeneous echogenicity. The radiographer also queried that these may be granulomas, but other parameters were within normal limit. She also did an echo, which showed a grade 1 diastolic dysfunction, no regional wall motion abnormalities, normal chambers, EF was normal at 60, and then normal IVC. Yeah, we can discuss the labs in the imaging.
Okay, thank you, Joseph. So these labs, let me start with the CBC with a leukocytosis of 12 with a predominant lymphocytosis, and then this mild microcytic anemia. So can I make anything out of this? I think no. So I know some pathologies. I think some endocrine, because as you can see, I think I'm more biased in the direction of an endocrine pathology here. Initially, I talked about thyroid dysfunction, and then with hypercortisolism. Of course, there's something else that I didn't mention earlier on because of the fracture that the patient sustained. And I said, of course, someone with sustaining a femur fracture from a level ground fall, that's definitely a pathological fracture. So the osteoporosis, I think, yes. So what was done, looking into the possibility that this could be myeloma, I think that was very important. That was important. So let's just talk about the monoclonal gammopathies in general. I think it's something that needs to be thought about. So I think at this point we can talk about monoclonal gammopathy of undetermined significance because we already see that if we are talking of a monoclonal gammopathy, so definitely that has to be something like symptomatic myeloma. with involvement of the bone. But then we didn't hear this patient presenting with bone pain. The patient has anemia, but the patient has anemia, but the anemia is mild. So so when you think about, I think this is an old mnemonic. If we are thinking of myeloma, we think about calcium, so it presents with hypercalcemia. So I think it was important to have calcium levels, which I do not see here. So I think I need calcium levels for this patient in 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 those extra investigations that I would need to order. We think about the renals. The creatinine as well as BUN are normal, but we see some protein in the urine. So this protein in the urine can be explained by a number of things. This patient is hypertensive, is diabetic, so it could be a nephropathy from those things that is causing the proteinuria. But then at least looking at the creatinine and the BUN, um, with those ones, we could say that the kidneys are spared. But then when we see proteinuria, we can say that the kidneys are really spared. We could be talking about early pathology in the kidneys. So I talked about calcium, I talked about the renals, and then anemia. We have anemia here, and then bone involvement. So pathological fractures are one possibility of bone involvement in myeloma. Uh, so uh, so I think yes. So I think it's myeloma would be a consideration, but then I mean this has been a very protracted cause. I mean I have to review my natural history of multiple myeloma, but this patient has been, or at least I should say, some of the symptoms that we are discussing started 10 years ago or more. So at this point in time, could we still consider, myeloma is a very aggressive disease. So that's what makes me hesitate to implicate everything that we see in this patient on multiple myeloma. But I think it was a very important consideration. So that's it about the CBC. So the leukocytosis, so some pathologies, I think patients with hypercortisolism, uh, can I remember correctly? I think you can see some leukocytosis, which don't really imply a lot, but maybe that's what could explain. I do not remember correctly. Uh, so the renals, the liver enzymes, liver function tests, electrolytes are normal. And then we see a HbA1c 3.4. It doesn't really mean anything. So we could say that from the diabetes standpoint, a HbA1c less than 7, patient within a patient on insulin, so this diabetes is at least on the long term is well controlled, uh, because we have achieved, I should say, with the insulin, the targets have been achieved. uh, and then a CA125. So CA125, this is especially for females, it's something that you see on some pelvic tumors like ovarian tumors. It is slightly elevated, and I think in the last presentation that I was talking about, that I presented ascites to a case of ascites to Joseph, I discussed a bit about these tumor markers that it's not wise to use them for screening because they are not specific, they are not sensitive. So this slight elevation doesn't ring any alarms. But then, so there is one thing. When I think about pelvic tumors, I know there are pelvic tumors. I think there is a good name for those, but they are something like functional epithelial variant tumors. I think uh, they can be functional, producing some things. So, for example, I was talking about ectopic production of ACTH. or so, but I do not remember correctly reading if ovarian tumors or any other pelvic tumors, if they can produce ACTH ectopically, but then this is a slight elevation in the CA125. And of course, we've heard about abdominal pelvic ultrasound. I think we didn't hear anything alarming in there. So I think if we do not see anything in the pelvis, I can bet and discard this without further investigation as to what is going on. But then we see some light chains elevated here in the kappa lambda ratio. I think Joseph, you'll teach me about this later because I know nothing about it, what it tells me, the lambda kappa ratio. So the kappa lambda ratio, I think later on you'll tell me what it implies. So I won't go into the details of that, but this elevation in the light chains I talked about. So yes, I mean, we could talk about myeloma, but something else that we can talk about is amyloid. So can I see the next slide? Yeah. So what makes me talk about amyloid is uh, these things that we see, for example, in the spleen. The spleen is normal in size, but then there is heterogeneous echogenicity. Anyone with anything?
Hello, David.
Yes, Joseph.
Something happened, and I just lost. I lost the network, kabisa, but no problem. So let me share again the slides. Oh, I'm very sorry.
Okay, no problem. Technical issues, they will never end.
Okay.
Okay, so I think we had already discussed these, so let's just proceed to the next one.
You can see my slide, eh?
Yes, yes.
All right. Um. So I think here now, if is there anything else you want to do, David?
Yes, so there are some other tests that I need to do. I do not remember. Yes, I mean, just like I said, I'm not really convinced that this is a thyroid pathology, but I need thyroid function tests. I need calcium. I also need cortisol. I need serum cortisol levels. I'll need ACTH levels. So I think that's what I need.
Okay. So TSH, I didn't write it there, but it was normal. What kind of cortisol do you need?
Okay, so I think yes. So the politics around cortisol. There's I think what's more important is AM cortisol levels. So yes, I think we can go with that one. AM cortisol levels.
Okay. So we decided to do a so-called low-dose dexamethasone suppression test, in which we gave the patient 1 milligram of IV dexamethasone at 11 p.m. and we collected blood at 8 a.m. the next day. So we sent cortisol in the outside hospital, and the result came back. It was written cortisol 1.8. The normal of that machine was 3.7 to 19.4.
Okay, so anyways, I think I'll have to review. I think I'll have to review the protocol around testing cortisol. I think so. Yes, I mean both of these can be used if you want to diagnose hypercortisolism. But then uh, if you so I think what I would be more comfortable interpreting would be the serum cortisol levels, because suppression. So if you do a suppression test, so what you are basically doing is you administer dexamethasone, right?
Mhm.
So dexamethasone is so that is an exogenous steroid, and what it does is it goes and suppresses. It's like a negative feedback loop to the pituitary, and therefore you suppress production of ACTH, and therefore you suppress ACTH, you suppress production of cortisol. So interpreting, so this one I see serum cortisol came back 1.8. 1.8. So what would this imply? I'm not sure if I'll get this one very correct, but then this is a low. This is a low level of cortisol. So what would this imply is if we are talking of primary hypercortisolism, that is if the adrenals are functioning, autonomously, they cannot be controlled by ACTH, then you expect a high level of cortisol regardless of the suppression test, because that means the production of cortisol is not under the control of ACTH. So if we get a result like this one possibility would be, if we are talking about hypercortisolism, then that means the culprit is the pituitary. Would that be correct? So uh, that means the adrenals are still functioning under the influence of the pituitary. That is, if you suppress the pituitary, then you suppress the production of cortisol. I'm not very sure if on that second part I'm correct. I think you will teach me more on that. So maybe in order at least with my ignorance on this one, I think I would be comfortable to see the serum cortisol levels first before doing a suppression test. So do you have anything else for me?
So, what do you think is a diagnosis in this case?
Okay, so the diagnosis in this case, I am thinking about hypercortisolism. I'm thinking about hypercortisolism, but I haven't been able to localize. I haven't been able to localize where exactly is this excessive cortisol coming from. Is it primary? That is it from the adrenal? I think based on my current knowledge, if I had an AM cortisol level, for example, which was elevated, then from there I would proceed now to do a suppression test in order to see now exactly where it's coming from. And of course, another thing that I will do is ACTH levels in order, at least based on my little knowledge. I'm not very comfortable with that one. I think I would have been able to interpret it better. So at this point, I'm thinking we are dealing with hypercortisolism, but then I haven't been able to localize where exactly. Is it at the level of the adrenal? Is it at the level of the pituitary, that is ACTH? Um, is it at the level of the hypothalamus? You have corticotropin releasing hormone, or is it ectopic production of ACTH, or is it exogenous?
Okay. Yeah, that's
Is someone is taking is taking in steroids? Yeah, so hypercortisolism.
yeah,
Yeah,
that's very true. And as you're saying, we also came up with the same thing, hypercortisolism, which Cushing syndrome, as the name suggests. And I can say I've learned a lot from you from the time you started discussing this case. So we'll go through what you went through. And then I will have my teaching points here, and I will teach each other some other things. So yes, very good points. That generalized weakness, which is presentation in this case, you say truly this is so wide you cannot pinpoint it anywhere. It can be some cardiovascular endocrinology, neuro, or even hematology. But again, the weakness that you said, it can be true neurological weakness or just coordination. It turned out it was true neurological weakness. You reminded us of the five F's of the abdominal swelling: fluid, fetus, fat, flatus. And so, very good thing I loved is that we should strive to find one thing which can explain all the things that patient are presenting with. Sometimes, yes, we fail, but we should strive to do that. And you made me remember it's called the principle of medical parsimony. You have one thing explaining other things. And yes, truly very nice. You identified thyroid diseases as a thing that can present everywhere because thyroid drives the metabolism, and metabolism is the body. And yes, truly, you reminded us of some presentations, some symptoms of thyroid diseases like weakness, insomnia, hypersomnia, trouble with menses, and other stuff. Also, you correctly identified the pattern. He had some sort of things, although you couldn't pinpoint others where are they coming from, but you could see multiple of them are going to the direction of that this patient is having an elevated levels of cortisol that is driving all that we are seeing. And truly, the next step is to find out where is it coming from. Is it the pituitary? Is it the adrenal? Is it exogenous? Which is very nice. I love that you saw the FUBA picture, leukocytosis, and just dismissed it because yes, it's nothing for this patient. The leukocytosis that we saw. Kappa lambda ratio, I put it here purposely because it was ordered, and then the interpretation it was a problem. So we all know that the the immunoglobulin has two chains, light and heavy. The heavy carries the name, the G, the A, the M, and then the light chains, kappa, lambda. So if they're elevated, that is not a thing. If you're inflamed, they'll be elevated. The thing is, what is the ratio? Because if you have a monoclonal gammopathy, that there is a clonal production, the clonal production doesn't produce both of them, it produces only one. So if you do the ratio, it will be, if it is elevated, that is a problem. But if someone is inflamed, they are all elevated and the ratio will be normal. So this patient, the ratio was elevated. I didn't mention it here. You will see in the outcome of the patient. At this point that this test was ordered, this patient had Aki. This patient had Aki. And think of those light chains. They have to come out of the body. How do they come out of the body? So the kappa starts with a K. It is taken out of the body by the kidneys. While the lambda starts with an L, it is taken out of the body by the liver. So if someone has liver disease or renal disease, you should be very careful interpreting these kappa lambda ratios. So this was the thing. I just hid that because it will be complicated, but very good that you agreed. Maybe you need some information from these. But it truly, if in a normal patient they're elevated, think of monoclonal gammopathies, and most importantly, three diseases: multiple myeloma, amyloidosis, and Waldenstrom macroglobulinemia. Yes, you reminded us of the mnemonic of multiple myeloma, the crab, very nice. But very nice, you say natural history doesn't correlate. This is a cancer. I can't stay for 8 years. Dismissing tumor marker was the nicest thing in this presentation. They are nothing. They shouldn't be used for diagnosis. And again, the radiologist would say things, but you as a clinician, as you did here, you look at them and say they don't make sense, and which also I did. So this is the case that I saw in hospital. And so as you did here, diagnose Cushing syndrome, wanted to know where it's coming from. We couldn't get ACTH because there was nothing labs that we looked around. So we opted that we'll do an MRI in this patient. But she had complications. She had a protracted diarrhea with blood stool. She had abdominal pain, fever. She developed acne. She developed chest infections, and she passed away. So we couldn't do an MRI. But later on, we'll try to suspect it based on clinical presentation. So I have some teaching points here. Cushing syndrome is nothing but a chronic exposure to excess glucocorticoids. Cushing disease is a special entity. If this chronic exposure to excess glucocorticoid is caused by pituitary adenoma, it is called Cushing disease. The epidemiology will depend with the cause of the Cushing. So for the Cushing disease, these are females between 25 and 45. This patient fell in this category. Ectopic ACTH production, mostly from cancers, so it correlates with the epidemiology of cancers, most above 50. Adrenal tumors, this is a bimodal distribution in kids and then in people between 40s and 50s. Etiology, most common cause, I've seen two cases in this thing. Most common cause, pituitary adenoma. Both of them were pituitary adenoma. Ectopic ACTH, 10%, and adrenal tumors, 20%. So to diagnose, you first exclude steroid use, as David did, and then three tests, David. The morning cortisol is not there. And it was the thing that this case was missed for all these 8 years. So the tests that have been found to have sensitivity and specificity to diagnose this disease, if they are also taken in combination, we only did one, but if we had, we could have do two or three. So you have bedtime salivary cortisol, 24 hours urinary free cortisol, and a 1 milligram dexamethasone suppression test, not to be confused with an 8 milligram dexamethasone suppression test, which is used to separate between in a patient with elevated ACTH, is it coming from the pituitary or ectopic ACTH production? That's another thing. But what you do for diagnosis, as what we did, is a 1 milligram DST. So how you do it, because this you can do it. We did it in the hospital and it doesn't need many things. So you give dexamethasone at 11 p.m. and then you measure serum cortisol next day at 8 a.m. And when the result came back and someone looked at it, someone could think, okay, they have low cortisol, it can't be Cushing, but everything else points to Cushing. So you go and look, there is a 2008 American Endocrine Society which says if the patient fails to suppress the cortisol below 1.8, that is Cushing, which happened in this patient. This patient had 1.8. So we diagnosed the Cushing with that. But after you diagnose that, that's not the end, because to treat, you have to treat underlying cause. You have to tell where is the excess cortisol coming from. We have a slide for that. So treatment will depend on the cause. If the pituitary, you have to undergo pituitary surgery. And I'll tell you, they do pituitary surgery in Tanzania. In Moi, they do pituitary surgery. I was in a clinic, endocrine clinic. I saw patient coming for follow-up. They had pituitary surgery. So this patient, if 8 years back, they could have had the diagnosis, maybe we could have saved. I don't know. And then if it's ectopic ACTH, you can find the tumor and excise it. If it's adrenal, you do adrenectomy. But in the literature, they write despite advances in diagnostic and treatment, mortality remains high. And the cause of death include atherosclerotic cardiovascular diseases, thromboembolism, infections. This patient died of infections, malignancy, and etc. So here are the signs of symptoms that I took from up to date, and I've put in red the one this patient had. So if you see them simultaneous or an accumulation of new features as the days goes on, you have to think of Cushing. So hyperandrogenism or hypogonadism, features like hirsutism. This patient had hirsutism, the hair and on the upper lip and the end, but it was not so severe. Decrease in libido, oligomenorrhea, acne, these were there. Metabolic, as you can see, she had central obesity, the baggy abdominal distension, normal ultrasound. She had diabetes, she had ecchymosis, stria, muscle weakness, low bone mineral density with pathologic fractures. She had hypertension, depression, impaired cognition, fatigue, current infections. And so how do you establish the cause? First, You can start with the clinical clues. So we know ACTH is a primary pigmentary um, hormone in the body. So if patient is hyperpigmented like this, ACTH is up. If there are severe signs of androgen excess, like balding in female, a lot of hair, not like this patient had, think of adrenal CA. Because females, most androgens in females come from the suprarenal gland. So if it has cancer, there will be a lot of them. But if there is mild androgen signs like this patient has, again, ACTH is up. If it's gradual progression, months to years, like in this patient, ACTH is up. So all these are pointing this patient had had an ACTH dependent disease, although we didn't do ACTH. But if it is rapid progression, then think of a non-pituitary ACTH production, like a tumor or something. But what you should do basically, you should do labs. You should order ACTH to tell, is the high cortisol driven by ACTH or not? So if you order serum ACTH and it comes back high, above 20, this is ACTH dependent. That there is a lot of ACTH coming in that are driving up the cortisol. And where is it coming from? You do brain MRI and see it. If you don't see it, and it is ACTH dependent, you do what is called inferior petrosal sinus sampling. It's a fancy name, but what it means is to take venous blood which drains from the pituitary. If that's not the case, it is not from the pituitary at all, then it is from elsewhere. So you do a pan CT, chest, abdomen, pelvis with contrast to look at a tumor in these places. But this is so rare. And again, if it is low, then it is ACTH independent. Only can come from one place, the adrenals, adrenal cancer, adrenal tumor, and stuff, or adrenal hyperplasia. So I've been thinking of this case for long now because not just for diagnosis, but the things that happened with this patient. She was there. She had a daughter who was a university student, and I was intrigued. I said, 8 years, so long. I asked to ask, has anyone ever done something like this to you? They said no. And anyone maybe done pan CT or MRI of brain? Actually, she could pay for all this. She had the means. And they said no. So when we saw this patient and I talked to the doctor that we are sending a cortisol, we think this is the disease Cushing. This daughter went back and read about the topic in the night, and in the morning she phoned my number and she called me. She said she was so disappointed because all these years they don't know what is happening. They've been out and in hospitals, different hospitals, but no diagnosis. And she said, this is what my mother had. Now she started telling me previously, yes, her mother had moon face and stuff, but I saw after 8 years, she was having atrophy everywhere. Even the cheeks were atrophied. So I could say, as the system, the medical establishment in this country, we failed this patient. We could have a diagnosis of something like this. And one thing that I think when we are interns or you are registrars in hospital to do everything, we can take from OBS what they do. If they fail a patient, maybe they call maternal mortality or something. It is discussed. Some people want to know what happened. They want to learn from the mistakes, but we don't do that in internal medicine here. And things go as they do. So I think that's very nice if we could be doing that. So like here, so other people are learning from it. We see the ways that you can share with other colleagues so that they don't miss something like this. Maybe catch it early at 3 years and maybe give a treatment to this patient. And this is the reason that we are all here at this hour. Not that to show that we know stuff or something, but to learn from each other. And for example, David now thought had to order a morning cortisol, but we're teaching each other, no, that's not the thing. You order morning cortisol only when you want to assess adrenal insufficiency, not hypercortisolism. Yeah, so that's is it. Maybe David, from you.
Thank you very much, Joseph. I should say, um, I think this has been a very wonderful welcome session. You know, I've been away for a few weeks, I should say, and this has been a very good welcoming note for the patient and the family, for the loss of the patient, and of course, as you said, I should just repeat what you said that. Of course, you know, me and Joseph, we've been, I think we developed interest in doing things like these because I think right from when we were doing residency, and at least we got to see some grand rounds from other settings and some expert clinicians discussing cases, and I think that's what intrigued us. And we thought we should start something that can help us share knowledge with each other. So mistakes happen, errors happen. We fail patients sometimes. You know, we patients can go round and round for years. A diagnosis is not made. And as I always tell my students, the first step to quality medical care is an accurate diagnosis. I mean, you can know the medications in the world, and for surgeons, they can know every single point to cut. But then, if you do not have a correct diagnosis, you won't do the correct thing. So, I think we should always remember that the first step to quality medical care is accurate diagnosis, and that's what we are trying to achieve every single day. So I think this is a huge lesson to us, to keep learning, to keep updating ourselves for the sake of our patients. But going back to the case itself, I think it was a very good learning experience. And for me, I think especially, I think these are very intriguing and confusing to most of us. Uh, Tests in endocrinology, especially the dynamic tests, because we have static tests and dynamic tests. I'm not sure if static is the correct word, but these are suppression and stimulation tests are what we call dynamic tests. Still very confusing, and maybe one possibility why they are very confusing is because these are not commonplace to us. I think we order them very few times, and at least for most of us, I think we've never ordered them or never interpreted them in real life, except from books and cases that we are trying to solve. So I think I've identified a few gaps. I should say many gaps that I should go and read and feel. So, for example, interpreting these tests, reading more about Cushing's and all the differentials that I was thinking about, and the thing about monoclonal gammopathies. Yeah, so I think it was a very good learning experience. And I should say, I say this is a jogging exercise. I did some real jogging, so I think I'm refreshed and ready to try more. Thank you very much.
Yeah, thank you. I think we are past the hour. And is there anything from anyone, any experience, reflection? Anyone? No one? Yeah. So I think we shouldn't waste more of your time. May I wish you a good night and see you next week. Bye.
Thank you, Dr. Joseph, for the nice presentation. I thought I learned a lot of.
I see Michael speaking. Joseph.
Yeah, yeah, Mike.
Yeah, yeah. I just said we are so grateful for that nice presentation. We learn a lot from this presentation. Yeah, we're going to pass a lot about Cushing syndrome, and thank you for the nice.
Yeah. Thank you, Michael.
So I should just say there's a couple of people whose attendance is quite impressive. You know, we started sharing these links to a wide audience just a few weeks ago, and there are some who at that point I should say were newcomers, but have been frequent attendants of these sessions. We are very happy to see you here because when I talk to Joseph, I tell him this that even if we share the links and no one joins, it started with the two of us. These sessions will keep continuing, but then we are even happier when we have a wide audience to learn from because we learn from each other. Only thing is, I think this audience has been a very polite and quiet audience lately. People do not speak as much as it used to be in the beginning, but regardless, we are very happy to have you around, and we hope that the audience gets bigger and bigger so we can learn from each other and improve the quality of the services that we offer. So thank you very very much, everyone. We are very happy and grateful to have you around.
Okay. Good night then. See you next week.
Okay, have a good night, everyone. See you next weekend.